Hello everyone and welcome here to our third primetime debate where we talk about digital dentistry. How far can we go? I'm currently here in our studios in Paris together with Frank Renoir. Frank, welcome back here.
Oh, how are you? Hello,
good.
everyone.
Yes, I'm glad you're with me on my side because this session will be run by our chair, Björn Klinge, with his two experts in our studios in Hamburg. But you and I will, about halfway through the debate, kind of interfere and introduce an interesting perspective on how technology and humans need to work together.
Yes, because, you know, our profession is not the first to have to deal with a complex digital equipment. And I have been discussing this topic with Mr. I have forgotten his
name. Yeah, your good friend. Yeah,
my friend is my friend.
The pilot.
The pilot, and we will discover after the lecture. And he's a pilot, and he's also a medical doctor. And his name is Régis Fusier, obviously.
There it is. Well, we'll hear from that about halfway through the debate. But remember, we are live. I have my laptop right here at the desk. So if anytime during the debate you have a question, an addition, a comment, an argument, make sure you take the opportunity to submit it right away. And with that, let's hand over to Hamburg. Björn Klinge, good evening. Whenever you're ready, take it away.
Bonsoir, Paris. Good evening, Paris. Good evening, the world. It's wonderful to have you join us here in wherever we are in Hamburg. Actually, this is a very unique situation for me. I come from the sunny, always sunny Sweden, and I come now to Hamburg. It's raining today. It's a very unique situation, but I'm still enjoying it. You know, there is a saying that all good things come three, and that's why we are three of us here tonight. We have Sven Mühlemann to my first left here, and we have also Stefan Wolfart. They are the experts tonight. They are both academicians. They are both clinicians working both with the surgical part and the prosthetic part of what we are going to discuss here today. So they know not only theoretically, but also practically a lot of what we will discuss. Published a lot. Stefan, you have your book out also with this subject, and so that could be recommended for everyone to dig into. We will have divided our tonight's presentation in three parts from us here. The treatment planning, the digital scanning or impression, and then the digital fabrication or execution of what has been digitally perceived so far. So let's start with what you have to introduce us to in this field.
Thank you, Björn. I would like to start with a clinical case. This young lady actually is missing 3 teeth in the lower mandible, and she would like to have them replaced. Today we have different options, and one option is that we have the possibility to acquire different digital data. Digital data means that we can acquire a CBCT scan, and we can also acquire an intraoral scan. And these are different data sets that are put together, and we are able to create a virtual patient. And the first thing that we have to do is we have to establish a prosthetic setup, because this prosthetic setup guides us through the complete treatment. Based on this prosthetic setup, we do our planning. And first we have to ask ourselves, where are we able to place the implants? Or maybe do we have to first augment the bone? Second, if we think we are able to place the implants, where are we going to place the implants? And what size and what length are we going to choose? So we have to ask a lot of questions that have to be answered. And it's important to know if you have the manual skills and also the knowledge to provide this treatment to the patient, or if you think that you better refer the patient. So this information is put together, and by designing later on a guide, allows us to transfer the implants that were placed in the virtual patient into reality. So the guide helps us to transfer this information from the virtual patient to reality. Second, we could also design a titanium mesh, because we thought in this clinical case that we have to augment bone. So this is already done in advance, and we are using specific design software that allows us to design this mesh, and later on, with the use of computer-assisted manufacturing processes, such as printing, we can fabricate a guide. So before we go into the surgery, we have already everything ready. Everything is prepared. All the materials are there, and we also know how we are going to design our flap, for example, because we know that we have to apply a GBR procedure. And this helps me a lot. And I think in the clinical situation, once we open the flap, and once I am sure that I'm really seeing clinically what I was seeing in the virtual patient, I can place the implants according to the planning with the help of a surgical guide. And once they are placed, I also can deliver the titanium mesh and fill it up with xenogenic bone substitute and fill it up. And it helps me a lot because I don't need to fabricate something during the surgery. So it's very time efficient. And once we finish the surgery, the next step will be then the prosthetic part. And the prosthetic part is just a copy of what we did already at the beginning. So we have the prosthetic planning, and now we have to copy that to the final restoration, which is a 3-unit fixed dental prosthesis. So to summarize, we are able to provide predictive treatments. We are able to provide personalized treatments in an efficient way. There's also evidence on this topic, and David Schneider and his co-workers were exactly asking the question, what are the benefits for us as clinicians? And they compared the conventional planning for implants to the computer-assisted implant planning. And they could show that we have to spend much more time for the computer-assisted implant planning. But on the other hand, there was also a benefit regarding the potential, the diagnostic potential. We could already know in advance if there's a need of GBR procedure. We already knew what kind of size and type of implant we are going to place, and also maybe what kind of or type of membrane we are going to use. So a lot of information that we can already have before the surgery, thanks to the virtual patient.
Thank you, Sven, for this exciting introduction to this complex issue. But now you've given us most of the professional perspective. It's us dentists that has been the focus now. Stefan, there is something else that is the key for whatever we do professionally, and that is the patient. How does the patient feel about these activities that we are doing using this new technology?
Yes, I think when we want to know what the patient is feeling, then we should talk to him. And therefore, I want to share with you an interview with a patient, and we go for digital treatment planning for him. So let's have a look at this video. Wir haben ja bei Ihnen im Unterkiefer mehrere Implantate gesetzt, um darauf festen Zahnersatz zu machen. Und zur Aufklärung der Operation habe ich erstmal Ihre Zähne gescannt. Wir haben dann eine digitale Aufstellung gemacht, also ohne Modell, und haben sie dann an einem dreidimensionalen Röntgenbild, wo auch die Implantate eingeblendet waren, aufgeklärt. Wie gut fühlten Sie sich denn auf die Operation vorbereitet und aufgeklärt nach dieser Operation?
Das hat mir sehr stark geholfen, dass Sie gesagt hatten, hier anhand der Bilder, hier haben wir noch so und so viel Platz bis zum Nerv. Also das war im Grunde eigentlich also wie bei einem Archäologen, der genau sagen kann, jetzt kommt diese Schicht. Also ich wusste es ganz genau, auch bedingt durch Ihre Aufklärung, da wird nichts schief laufen. Diese Aufklärung hatte mir schon sehr, sehr viel, ja, sagen wir, Entspannung mitgegeben.
Okay, sehr schön. Sage ich mal, so eine Hightech-Aufklärung, wie wir es jetzt gemacht haben, schafft es zusätzlich Vertrauen für Sie?
Definitiv.
Ja.
Also ich muss jetzt sagen, nachdem ich es genau sehen konnte, auch mit der Schablone, also wirklich, das ist ja so ähnlich, denke ich mal, wie bei einem Flugzeug. Also man sitzt als Passagier und man gibt sich also in die Hände des Piloten und man geht fest davon aus, dass der wohl sein Handwerk beherrschen kann.
Jetzt, also die 3D-Analyse hätte es noch nicht gegeben. Ich hätte eben nur so ein Röntgenbild, wie Sie es jetzt sehen, also in einer Dimension gehabt, ja, und hätte Sie daran und an Skizzen aufgeklärt. Rein hypothetisch jetzt, glauben Sie, das wäre genauso gut gegangen?
Wir hätten die Sachen, die wir jetzt vorher gemacht haben, die haben natürlich zusätzlich zu meiner Beruhigung beigetragen. Ich muss aber fairerweise sagen, ich hätte auch sonst das Vertrauen zu ihm gehabt, zu sagen, der macht das schon ordentlich. Ja.
Yes, for me, it's beautiful how colorful he described that he has additional confidence through all this technique according to the surgery which we have done later. And he said he knew exactly what will happen, and this information gave him a lot of relaxation for the surgery. And on the other hand, it was very interesting that he said, I would have confidence in you in any case, even if you use only a two-dimensional X-ray and sketches and so on. And therefore, I think the dentist is also a very important part in this. But on the other hand, this was only a voice of one patient. So let's have a look what science is telling us about this, what evidence we have. And for this primetime debate, we prepared a systematic review. Dr. Bishti and myself, we started with that. And for this question, freehand protocol versus digital implant planning, we could use 5 studies. And the outcome of these studies were pain, number of painkillers, the patient used, swelling, and the satisfaction about the surgery. And the results of this meta-analysis was that generally the patient preferred computer-based technologies. However, there was no difference in the intra and post-operative discomfort at all. So there was only one indirect correlation which we could find, that a combination of navigated implant placement and flapless procedure that in the end will lead to less pain and less discomfort. So if we put all these pieces now together to one part, then we have evidence that the patient will prefer that the patient will prefer these computer-based treatment planning. However, we have no difference in the post-operative outcome, which means connected to the patient-related outcome measures. From the psychological part of view, then we can say that the patient feels much better informed, and however this could lead also to an increase of confidence to the surgery and to the clinician. And this gives us also a responsibility as dentists, because we have to make the informed consent as good as possible. And if we have 3D data, we could make it much more clear for the patient than with only a two-dimensional X-ray. And on the other hand, the implant placement is much more precise if we used a navigation template. However, the challenge for us dentists is that we really have to control this technique, and it's not so easy to go all these steps in the right way. So, and in the end, we have to accept that the navigation template is only a tool which we can use. That the surgery must be done by ourselves, and we need the skills to do that. And that's my point, which I can make here.
Yeah. So far, we we are now on the planning phase, and we are discussing a lot of where we are now. So, Sven, do we have any perspectives here?
Exactly. We are asking ourselves, how far can we go?
Right.
And I would like to share a video showing one example of how far we can go already, and maybe in the near future. And it's a video showing the application of augmented reality. This is an app which is available on a tablet, and it allows to immediately show a prosthetic setup and immediately show this prosthetic setup, and the patient can follow this by moving his head. And what I showed before is that we have to spend a lot of time for the planning, and we have to include the dental technician, so it's always a team approach. But when I see the patient first, he has some kind of expectations regarding his situation, that he has a worn dentition and he wants to have this tooth substance replaced. And he has expectations, I have the knowledge, and I think using this application, this augmented reality, helps to immediately visualize a possible treatment plan. And I think that's the beauty. And maybe in the near future, this augmented reality is also available for us as dentists, that we can immediately superimpose a prosthetic planning on top of or in the mouth, maybe.
Yeah, you should note here, Sven, and I'm sure you did, that the expression of the face of the patient was the same regardless of what treatment he got. So that brings us a little bit further back to the patients again. Stefan, what is the patient here, and what do they say about this and their expectations?
Yes, I think the first time when the patient realized that we are doing something digital is a digital impression, is when we start with the prosthodontic treatment. So it's important to look at this point how the patient feel with a conventional impression or digital impression. And again, I want to share with you an interview of a patient where we have done both. And now we want to have a look at that. Diese 6 Implantate werden auf konventionelle Weise und mit einem digitalen Scan abgeformt werden. Und wir sind sehr gespannt, wie sich das für den Patienten anfühlt und welche der Behandlungen er angenehmer empfindet.
Und ich muss sagen, ich persönlich finde das eine tolle Sache, dass man eine dreidimensionale Struktur digital aufnehmen kann. Und das ist ja meist eine relativ genaue Vermessung. Also ich persönlich finde das eine sehr positive Entwicklung.
Wenn ich Ihnen sage, beides ist genau gleichwertig, Sie können sich aussuchen, was Sie wählen würden, was würden Sie von beiden wählen?
Also ich würde eigentlich immer die digitale Variante wählen, aus dem Grunde, weil man nicht so gerne Chemikalien im Mund hat.
Okay.
Ja, mit diesem Abdruck und so. Das ist jetzt auch nicht schlimm. Aber im Laufe des Prozederes bis heute oder so hat man ja schon Schlimmeres erlebt. Und da würde ich sagen, da würde ich das Digitale eigentlich immer vorziehen.
Okay. Häufig ist bei Patienten so, dass sie beschreiben, ich habe eigentlich Angst, dass das vielleicht wiederholt werden muss. Haben Sie sowas?
Mir geht es ja darum, dass das Endresultat gut ist.
Ja, genau.
Und dann ist man auf dem Weg dahin, glaube ich, ziemlich geduldig.
Ja, das ist ein ganz wichtiger Punkt. Ist es für Sie so, dass Sie sagen, okay, wenn da jemand solche Technik anwendet, dann stärkt es auch das Vertrauen, oder hat es miteinander nichts zu tun?
Also ich würde mal sagen, dass das davon unberührt ist eigentlich, weil wenn ich mich in Ihre Hände begebe, vertraue ich Ihnen ja ohnehin vollständig. Ja, und insofern glaube ich, dass Sie die richtige Wahl treffen, und ich vertraue Ihnen ja auch als Experte auf dem Gebiet, dass Sie das alles 100%ig beherrschen. Von daher sehe ich da keinerlei Unterschied.
Okay.
So for me, it's very interesting that he could give us really a very impressive thought, that he could structure very impressive his thoughts about what he thinks about the different impressions which we have done in his case. And so we can summarize this, that he said, okay, I would always choose a digital one because I don't want to have any chemicals in my mouth. However, he said, but the normal impression is also not too bad. And then the most important point for me is that he said, okay, I trust you as an expert. You have to choose what is the best for me in this situation. And his main concern is that the final restoration is perfect in the end. So that gives a lot of pressure back to us so that we are able to find the right treatment for him in the right situation. But again, this was only the voice of one patient. Let's look at the evidence which we have in this case. And also here, Dr. Bishti and myself, we performed this meta-analysis and we compared conventional versus digital impressions. And we included 7 studies, and the outcome was that we found out something about time, about taste, about nausea, pain, shortness of breath, and discomfort. So let's come to the results of this study. And we could make a long story short. The evidence was that from the patient point of view, the digital impression was not faster than the conventional one. And on the other side, the patient reported less discomfort, less pain, less shortness of breath, and a better taste for the digital impression. So the psychology behind it is, in my eyes, that they are very impressed from this new technology. When they see when they could watch at the screen and see how the whole mouse is, the whole digital teeth are starting to be on the screen. And this increased also confidence in the clinician in some cases. And for us, I think it's a big responsibility that we are in control of this technique, that we have made a good learning curve with that, and that we really can use these scanners. And on the other side, the indication must be the right one. So we really have to look if this situation, this clinical situation is fine for the scanner, and that we have evidence that especially in this situation, we have enough accuracy with these scanning systems.
Yeah, do we have that? Sven, let's go to the clinical reality here. What do we have to make sure that we kind of bring into this that also, of course, benefits the patient?
Yeah, and we have to ask ourselves as clinicians, what is the benefit when I am using an intraoral scanner? And if we look at the data, and we run a study in our clinic where we recorded the time when we take digital impressions and also when we take conventional impressions, and the result was that we gain time, and this was statistically significant. But if you look at the numbers, it was only 5 minutes. And we have to ask ourselves, is this really clinically relevant that I can save 5 minutes? I think that's the wrong question. When we are using digital technologies, I think it's very important not to just exchange conventional techniques by digital techniques, but thinking of how can we change the workflows, and we can apply new workflows. For example, once we place the implant, we could immediately take a digital impression, so we can actually save 1 appointment. Well, 1 appointment doesn't sound a lot, but if you are living in Beijing and you have to attend an appointment, you are going to lose the whole day, working day, and this is very essential and very important. So we can follow new workflows when we are applying digital technologies. I think that's really a great advantage. And I would like to come back to the surgical execution also. Just here a picture where we could deliver the 2 crowns. But also going back to the execution, we have seen also in the evening the possibility of placing the implants with an dynamic implant navigation, and shown here. And I think this is really nice because our manual movements are tracked, and we can see on a screen our prosthetic planning and also the virtual planning of the implant. And we can always check if we are on track or not, and this is done immediately. And I think that's really great. But still in this case, so for this method, you need to have the manual skills. And I think the next step, and the question is again, how far can we go? I think we could combine the two methods that are available right now. On the one hand side, we have the guided implant placement, and I think that once you are sure that everything is as planned, the execution is really simple. So that's a benefit. And the benefit of having a dynamic implant navigation is that I know where I am. So if I need to do a change, I have always the control by seeing the images. And an important result of the study by David Schneider and co-worker was that when we do an implant placement guided, in 50% we need to change the protocol. And if we change the protocol, I think we need to have expert knowledge in order to be able to change it and still to deliver the implants. So combining those two maybe would be the next step. In the near future, maybe we have the combination of these two methods.
And we will come back a little bit more to the challenges and the conflict here between what a little bit up to now a blessed story of using new technology with the problems that also may occur. If we now move into our third and last section here, just calm down in Paris. We know that we are on the third and last section here in Munich. So your patient, again, the core of what we do, what's their reaction here when we apply the methods to the patient?
Yes, in the last step we could fabricate the restoration with a conventional, with a hybrid workflow, or with a digital workflow. And again, we want to listen to a patient. And with this patient, we have done a complete digital workflow. And let's hear what he has to say. So we are waiting.
Also Herr Graf, wir haben bei Ihnen ja, haben die Backenzähne gefehlt praktisch und wir haben daraufhin jetzt dort Implantate, Kronen und Brücken gemacht und wir haben das eben mit einer dreidimensionalen Planung gemacht und dann auch, wir nennen das navigierte Implantation, sodass wir die Implantate wirklich genau an die richtige Stelle setzen konnten und anschließend dann das Ganze mit einem digitalen Scan abgeformt, also nicht wie normalerweise mit einem Abformlöffel oder so, mit Chemikalien, mit Materialien im Mund, sondern mit einem Scankopf abgescannt. Und anschließend sind auch die ganzen Restaurationen mit einem CAD-CAM-Prozess hergestellt worden, also nicht mehr mit den klassischen zahntechnischen Methoden. Und einige der Dinge haben Sie bemerkt, andere Dinge haben Sie praktisch nicht mitbekommen, weil die im zahntechnischen Labor passiert sind. Und mich würde jetzt einfach interessieren, wie zufrieden sind Sie denn jetzt mit der Arbeit, die wir jetzt eingegliedert haben und die Sie jetzt seit ungefähr einem halben Jahr im Mund haben?
Die Frage kann ich nur beantworten, sehr zufrieden. Ich habe keine negativen Einflüsse. Ich kann gut essen und kann gut schmecken und kann gut sprechen.
Okay, super.
Die Digitalisierung ist mir sehr entgegengekommen, weil ich sehr empfindlich bin im hinteren Rachenraum.
Okay.
Und dass die moderne Technik was Besseres herausbringt, zumal ich ja diese Probleme habe mit dem Löffel. Diese Brechreiz sind dann immer.
Okay.
Deshalb kommt mir das sehr entgegen.
Okay.
Ich bin eigentlich mit allem zufrieden. Ich würde gerne das nochmal machen lassen.
So, I think it was really clear that he was really satisfied with this work, with this complete digital workflow. And on the other side, he told us that he thinks that modern technology brings out something better. And this is something which we have to discuss with Sven afterwards, if it really is like this. But first, we have to look at the literature again, what we can find about the comparison between conventional and digital fabrication process. And here we could add only 2 studies in this meta-analysis, and we looked for function, for aesthetic, and for general satisfaction. And the important thing is that all cases which were treated in these studies were only single tooth or small bridges, and all this restoration were in the posterior zone. So let's have a look at the results. So the results showed that the patient-reported outcome measures, there was no difference between the two workflows.
Only in one case we have this difference because when we look at aesthetic outcomes, we have a better aesthetic outcome for the veneered crowns than for the monolithic zircon oxide crowns. And if we put this together, then the psychology behind it is that it is not of a primary interest for the patient what kind of workflow we are using in the laboratory, because he could not see it. And the responsibility for us as a dentist in this situation, in my eyes, is that we have to check if you really need a better aesthetic outcome, like we have it for the veneered crowns, or if it's more important for us that we have a 30% reduced treatment cost for the monolithic zircon oxide crowns, for example. And so we have to be sure that we adapt the selected workflow to the desired results of our patient in the end.
And Sven, we are now to wrap up this three.
Yes. No, Björn, you don't have to wrap up just yet. So, I would like to bring in a question from our audience members. We have, when people were listening, this is great stuff, guys. Björn, Stefan, Sven, this is really interesting. And keep going as planned. But we want to introduce a quick question from Andrea, joining from Budapest, which came in when Sven showed us the super cool augmented reality application, and also with Stefan's patient interviews. She's asking, is there a risk that showcasing a perfect but theoretical, and in this case digital result to the patients ends up causing disappointment when reality brings in the real complexity? It's just to add on your discussion.
Yeah.
And I think that, Sven, would you like to go out or would you like to answer the question?
No, it's a really important question. And we have to be careful when we apply digital technologies. And it's true that this augmented reality app is just the first application, and we have to be careful. And as far as I'm informed, this app, or the ones that are producing the app, they are going to somehow use a CAD software and combine this CAD software to the app. Therefore, we are able to somehow include also the anatomical situation, so that we are not completely ignoring the bone and the soft tissues or where are the teeth. So this is really important, and I think we need to have a basic understanding of computer science, of computer vision, and it's always, we have to be responsible, and we have to keep that in mind, and we have to. Once the patient thinks, well, I would like to have this prosthetic treatment, still we need to go back and apply the conventional method by doing a mock-up, just to not disrespect like the anatomical situations. Yeah. Very important.
I think that we will have to cut answering there. Would you round off with your last slides?
I think we don't need the slides, actually, because one important message that we heard from the patient was that when we apply digital technology, the outcome is better. And I think as clinicians, the benchmark is set by our conventionally fabricated restorations. And the goal should be that at least we can achieve the criteria of clinical quality with our CAD/CAM restorations. And I think we have the evidence that we are able to. We also have the evidence that we are much more efficient, time efficient, so we can save a lot of time in the dental lab. And on the other hand, however, we have to know that this is only true for the single implant crowns and mostly in the posterior. So the evidence is there, but it's limited to single implant crowns.
Yeah. Thank you. And as you understand, in Paris, we have highlighted the positive ways of using this new technology. We are fully aware of limitations, and we will now send this message over to you in Paris. Please help us out a little bit about the limitations of this technique, because we are aware, we just want to know if you are.
Exactly. Thank you very much, Björn, Sven, and Stefan, for this very interesting exchange so far. So indeed, you make it seem like it's a no-brainer that both from the dentist and the patient perspective, we all have to go fully digital. But it might be that we have to be a little bit more cautious, right, Frank? Because I discovered on the internet last week a clip of you in an airplane cockpit talking to a pilot. Who did you talk to and what did you ask him?
Yeah, first of all, it's very important to accept that the digitalization is now part of our practice. It's no doubt, no discussion, and that will be more and more present in our dental offices. But we have also to accept that whatever the procedures or the new technology, we have always a side effect. And the question is, could we trust 100% in a digital health? And the digitalization in dentistry, and we have to accept, is pretty new. It's, let's say, 10 years in a dental offices. Mm-hmm. It's not a lot to analyze the side effect. And who better than a pilot can treat this topic? And let's imagine that we know a pilot who is also in a medical field. His name is
Régis Fouget, I think. That's his name. All right.
And this person, a good friend of mine, is a professional pilot, but is also the head of the anesthesiological department of the Cancer Institute in Toulouse. He has a huge experience in both medicine and aviation.
Well, let's have a look at that interview.
Yeah, please.
So I understand that in OR or in the cockpit, the computer help us to fly safer and not simpler, but at least safer. But what happens if the system failed?
Well, in commercial aviation, there is a redundancy of the different systems that allows to fix immediately a computer in case of failure. Moreover, pilots are trained to complete successfully their mission, even should many failures occur.
Okay.
It's a little bit different in a theater or operating room. In case of computer failure, we have to practice manually both the anesthetics administration and the monitoring of the patient. This increases the workload for sure.
Okay. So I understand that in case of failure in a cockpit, you have a multitude of helps, but in the operating room, it's a different, and you have to return in a conventional way. Do you think that we do need a specific training for the people who use digitalization, whether in dentistry or in medicine, surgery, in anesthesiology, in the medical field in general?
Of course, of course. I will say that in aviation and medicine, it's mandatory to understand how the information from digitalization is gathered and presented. That's why a specific training is mandatory to explain that such approach are more complex than a simple line to follow. A similar answer can be made for medicine. A training based on a computer-assisted procedures solely put at risk of difficulty if a computer failure occurs during the surgical procedure.
Okay, if I understand, the limitation of digitalization in medicine now is most of our colleagues, the young generation of colleagues, who use only the computer in case of problem, in case of failure, can have a problem to go back to the conventional way to open stomach or to do use an implant procedure without a fantastic surgical guide. And this kind of procedures and training, I know in dentistry at least, is not discussed. Very, very rarely. And we must be very careful about this focus on the fantastic tool, could be a computer, because sometimes the computer fails. and we have to be able to go back to another, and to use another way. So, and now last question. In dentistry, for new generation of dentists, digitalization is presented as the solution to push the complication far away. It seems to be so nice. It seems that you have just to be a geek and you can treat all the patients safely. What do you think about?
Well, according to what I've said previously, I do not think that digitalization could be considered as the solution. Of course, the systems can help the practitioner in his daily practice, but the system brings a new issue. For example, what is the reliability of the system? How can I confirm the data presented by the system? And how will I have to manage the patient in case of failure, for example? In all cases, I think what's very important that in all cases, the practitioners have to maintain control over the machine.
Yeah.
At least they have to make sure that what the computer proposes matches with what they expect.
Yeah.
So that looks like an interesting journey, Frank. I hope you were flying autopilot because I saw no hands on the wheel.
Yeah.
When I listen carefully here to your conversation, I hear that there's a risk of relying too much on the technology.
Yes.
That we should be trained to handle the situation when the machine fails, and that we should be trained in where the data comes from, right?
Yes,
So
yes.
that is the key point you want to make here. Now, earlier today, you told me about this study in the Foch Hospital where they compared anesthesiology aided with or without computer simulation.
Yes.
What did they find?
That was a simulation, and to make very short, you have two models, and one model was in a group was giving anesthesia, fully assisted by computer, and second one, old style, recording manually all the parameters. And suddenly they stop the anesthesia. Imagine the machine failed. And they ask the people, okay, could you give us the parameters of the patient? The simple one, oxygen, apnea, and
simple, but vital ones.
One. Yes,
yeah.
but vital one.
Yeah, yeah.
And surprisingly or not, the people were using fully assisted procedures were not able to give back the different parameters. That means that if something is wrong, they don't know where they are and where they are, how many drugs and hypnotics they have to give or to remove, or etc. And the full conclusion of this study showed that the people who are using only computers and who trust 100% computers has a very low situational awareness.
Aha. So it's interesting that there's already some studies coming out to prove that there is a true risk in relying too much into technology. So let's try if we can turn this twist into the Hamburg studio. Björn Klinge, we're getting some comments, for example, from Ralph Kohal, who really enjoys your jokes. So keep that up. But what we really want to learn is when the problem occurs, first of all, how do you realize that there is a problem with a digital system? And secondly, how do you address problems in a problem solving in a digital workflow?
Yeah, I will bring these questions to my two experts here. And first, I'll just say hello to Ralph Kohal and saying that there has been no jokes through until now. So it's very serious matters here. Beware of that. Sven, how do you look into these questions? How can you get in control? How can you know that something is a problem?
I think you have to have an understanding of also of the conventional protocol. And if you are planning an implant placement, for example, and you transfer the data by means of a guide into the patient, the first thing I do is I really check if what I get with a first pilot drill, what I was planning. And this is very important. As soon as I verified that I really get what I planned, I can proceed. And these are conventional measures. So I remove the guide and I place the first drill. I check if this makes sense, if this is really what I was seeing on the computer. And this is very important that we don't just rely on the guide and we follow the procedure no matter what the result is. Very important.
Stefan, do you agree or disagree here?
I agree completely, and I could add how I will do it with for example, for digital impression. I think when I have a new scanner and I want to test a new workflow, then normally we have no scientific data for that because when it's a new scanner, we have no data. And therefore, I can recommend that you should do a normal, conventional impression and also digital impression. And then the conventional impression is always the gold standard. So then you can work on the digital one and you can have a look if the restoration is fitting also on the conventional. That's a good way how you can find the right workflow with your dental technician together. And if you see you have a failure, then you can stop the digital treatment and go back to the conventional. So that's one possibility how you can manage the prosthodontic part, so that you really can see, okay, there is a mistake, which I have to solve, and then you solve it with the conventional technique.
So that means that one of the key take-home messages from Hamburg, and I think from other places too, is that it's not either or. It is a good combination of this new digital technique with conventional, because you must have the understanding of how to handle the whole situation. Back to Paris.
But can I add one more thing?
I think we are back to Paris.
You can add more things, Stefan, but we have a few interesting comments and questions from our audience. For example, one of our debaters last night, Ignacio Sanz Martin, is now safely back at home, and he's writing, if you say, Sven, that you always need to know the conventional knowledge to be able to handle the situation when things go wrong, are these digital protocols then only for experts? I also would like to add on that, what happens then to the younger generations who never worked with these conventional protocols? What happens if they are in the hands of fully digital and then things go wrong? We'd love to hear your comments.
Will you start, Sven?
Yes, a very also important comment from Nacho. Yeah, we have to, I mean, what is really nice, and I tried to show that at the beginning, is that we can first plan the treatment and we can ask ourselves if we are able to execute our planning. And I think this helps also the ones that are not that trained, and because we have the ability to share this planning through the internet, so we can always ask a colleague to look at our planning. I think this is also something that was not able before, so we can share our cases and we can discuss different options. And I think this is actually an advantage, that we can select what we are able to do and what possibly we are not able to do. And still, I think, yes, there needs to be, you need to have knowledge regarding the conventional procedure, but let me add one thing, is that when we are in a cockpit or when we are in the OR and there's a general anesthesia, we have to finish this procedure. And in implant dentistry, I think we have to have the courage, when we realize that something is not as expected, to stop our treatment and just suture, finish the surgery without placing an implant and without performing a GBR procedure. So anytime we can stop when we don't feel safe. And I think that's a huge difference to when we are sitting in a cockpit or when a patient is in general anesthesia.
And also I think that we agree, that's one of the problems here in this debate, that we do agree on a lot of things, but we cannot remove the conventional from the traditional education. It has to be there as the foundation for the new technology. And it's not to say that I am or we are against new technology by any means, but it is to make the best of it that we need to compare with the conventional. Stefan, a comment.
Yes, I can add perhaps that if you go to removable dentures, for example, and removable partial dentures, it's also a very important thing in implantology. Then you always have to use conventional techniques. It's not possible without conventional techniques at the moment. So it's not that way that a student does not learn conventional techniques anymore. It's clear that he has to learn both in the moment. Perhaps it's a little bit like with the digital cameras. When we have the analog camera systems, then there was a long time where both systems were working fine. So we have advantage for that and advantage for that. And then after another 10 years, we came to a point where we don't use analog cameras anymore. So that's a situation which we perhaps will get in a lot of years, but in the moment, and especially for the removable partial dentures, we don't have the situation. So we always will teach our students also the conventional way and say, should use it. And I'm completely with you. The big advantage in dentistry is we don't have to react immediately on special situations, especially if it comes to the prosthodontic workflow. If we see the scanner is not working, we can say, okay, we can't do it today. We have to check the scanner and come back tomorrow. So it's not a problem.
One thing that we will not have the time to discuss tonight is that the market is flooded with new technology. And most often, science or research tries to, come timely to what is introduced. And if you add one new scanner with one new of this, with one new of that, there is a risk that we also add more problems. We'll have that in a separate session, hopefully next year. So
Björn,
back to
yes,
Paris,
because,
I think it was.
when Sven mentioned that you have to be ready to perhaps abort when things go on, I think Frank almost jumped off his chair. So Frank, you'd like to comment on that?
Yes, because this comment, thank you, Sven, it's a very, very interesting comment. We can stop the procedure. But Sven, in aviation also, we can stop the procedure. Before takeoff, we always foreseen the possible problem, and we have the different airport where we can land in case of problem. And that is the anticipation. And in aviation, we have in our mind that something can be wrong. And even if you have a lot of computers in our cockpit. And the only weak point I notice in digitalization in dentistry is we always talk about the fantastic procedures. That is true, but we never ever talk even to the younger generation that sometimes something can be wrong and they have, before takeoff, they have to know where they have to land in case of problem.
Please respond, guys.
I think you can see that we are nodding in Munich, in wherever
Germany,
we are in
Germany,
Germany,
Björn,
in Hamburg. That is a very typical German expression that we do agree. We do agree, Frank, and that's a problem. We wanted some more controversy here, but we do agree.
All right.
Good.
Well, thank you very much, Björn, Sven, and Stefan, for this very insightful exchange. Well, Frank, there's one more thing to do. We need to safely land this prime-time debate, although it didn't get in a very heated fight, but I think we got a good, different perspective on both opportunities and perhaps some risks and limitations. Okay. Let's go back to the cockpit and see how you ended that flight.
Regis, now we are approaching Göteborg, where we are supposed to land, and now we have to prepare the procedure for landing. Please, have you some word to conclude?
Well, to conclude, I would say that digitalization has improved the safety in many procedures in the domain of aviation and medicine, provide that conception and organization and the limits of the systems are integrated during the learning and training courses. As mentioned earlier, the main objective of the system is to assist the pilot, the physician, but not to substitute him.
Yes, I think it's a fantastic conclusion.
Thank you.
It's a help. Is not. We don't give the key of the truck to the machine.
Exactly.
We have to control all the time, and to have the situation awareness means we have to be aware about the data we put in the machine and the data the machine give us back. Yes, good. So it's time to go now.
Let's go.
Let's
Thank
go.
you.
So, almost time to go now. You really landed in Sweden, I guess, paid a visit to Björn?
Yes, we landed in Göteborg and very safely. Regis is a very good pilot.
All right. So just to wrap up, I'd like to take these messages from today where you say we need to be aware of conventional working methods, we need to train extra awareness. Where does that land in the protocols in our daily practice? How do we make this hands-on?
It's in a daily practice, I imagine that now in the future, most of the practitioners will use the digital ways. And that is a development.
That is a given, yeah.
Yes, but the problem we know in general surgery, for example, for the celioscopy, and now it's very difficult for the new generation of surgeons to open the stomach very quickly if you have a failure of the hepatic artery, liver artery,
yeah.
And they don't know how to solve this problem.
Yeah, so you pointed that out clearly, but what do we need to do to make them ready?
We need, first of all, we need that the experts in digital dentistry now sit around the table and talk about the problems.
Okay, but so a problem is our youth will not know our conventional working methods.
Yeah, and the second, during the education, that is what Regis told me during the interview. During the training, the pilot learn how to land with the satellite, but also in case of loss of satellites, they have to follow the conventional way, ILS. And in dentistry, we also need to teach a student how to place an implant if the surgical guide fell down, it's not sterilized again, if the surgical guide is not offered, if the surgical guide is a surgical guide to another patient and delivered by error in your office, that will happen. That will happen.
Yeah.
And these people, the new generation, must be able to place an implant without any computer errors.
So would you say that the main follow-up action after participating in this debate and listening to this evening is that we make our educators aware that they keep the educational programs broad and keep them work with like operating with knives and forks?
Yes, please.
All right. Well, that's a very clear take-home message.
Yes.
Let's hope from now on, 10 years down the road, if we look at dental schools, they still have, and people say, why are you still doing these old methods? They say, well, primetime debate. EAO Digital Days. Well, Thank you very much, Frank, for your contribution tonight. And thank you all for adding your thoughts via the platform and your active participation so far. Now, if you're curious about what else you can learn from our pilot, you can make sure that you check out the third part of the interview Frank had with Regis Fouget, which is available in our video on demand section on the platform.